The American College of Cardiology is pleased to present this online education program titled Patient Navigator Webinar Number 1. We are very pleased to welcome all of you here today. Now it is my pleasure to introduce Ty Gluckman, MD, FACC. Welcome to the program.
Eric, thanks for the very kind introduction, and thank you to all of you who are dialing in and participating in today's webinar. I have the distinct pleasure of serving as the chair of the steering committee for the Patient Navigator program, Focus MI, and I'm going to be taking the opportunity over the next 60 or so minutes to be able to share with you information about this National Quality Improvement Initiative, and we'll be going through a series of slides. As we go through this, to build on what Eric led with, I would reinforce to you that you can type in questions in the chat box as we go along. I will do my best to answer them in the context of the next 60 minutes, but in the event that we are unable to answer the question, we will try and circle back with you to be able to answer and address your questions that you may have. So without further ado, I want to roll out some of the webinar objectives for today's call. Our goal is to describe the goal of the Patient Navigator program, Focus MI, again, a newer National Quality Improvement Initiative launched by the American College of Cardiology, and we're really excited to be able to share this information with you today. In addition to this, we're going to discuss how to utilize the data collection tool, and we'll share a bit more about that with some screenshots in just a little bit. We're going to explore the QII, or Quality Improvement for Institutions website, which is a tremendous resource not only for opting into the program, but also accessing a lot of the tools and materials that are available to help support you in quality improvement initiatives related to this topic and many others as well. We're going to talk about setting goals, and obviously anytime one embarks on a quality improvement initiative, it involves doing an assessment of areas or gaps, areas in which there are gaps in care, and then identifying and setting those goals, leading to hopefully future quality improvement. So this is the scope of the problem, and we have a couple of screenshots to represent this, but I think this is perhaps well known to most of you on the call today. Unplanned, unanticipated readmission for Medicare is a major problem, and two of the biggest drivers that account for unplanned readmissions amongst the Medicare patient population are that of heart failure on the left and acute myocardial infarction on the right. The remainder of today's call is focused only on the myocardial infarction patient population, but as you can see there in 2010, admittedly 8 years ago, about 20% of individuals with a myocardial infarction, hospitalized for a myocardial infarction, got readmitted within 30 days of their discharge for their myocardial infarction. And represented a different way here is that about 1 in 5 myocardial infarction patients will be readmitted within a 30-day time horizon, and often these patients are readmitted far earlier than the 30-day mark. They may be even readmitted in the first 24, 48, or 72 hours following discharge. This comes at a tremendous cost, estimated about $17.4 billion annually for the total cost of readmissions, and obviously, perhaps well known to many of you, has led to the readmission reduction program launched by CMS, by Medicare, in an effort to curtail unplanned readmissions with imposed penalties on hospitals and health systems that had higher than expected or anticipated rates of readmission overall. So the Patient Navigator program, in a nutshell, is focused in on improving care for cardiovascular patients, and it has some underpinnings reflecting the goal of being patient-centered. It is attempting to leverage the best evidence-based information that we have to drive best practices. And it very much relies upon and demands a team-based approach. And I think this is well known to many of you, but it's really hard to move these mountains doing this alone, whether you have an engaged clinician, an engaged nurse, an engaged administrator. one of those individuals by themselves is really hard to move the needle. It really does require a team-based approach, and centers that have done this well have not only leveraged those three groups of individuals, but members of the entire care team, not only in the acute care setting, but in transitioning to the ambulatory setting as well. So this next slide talks about program goals, and these are goals that actually reflect what we did in part of the Patient Navigator Program 1.0, or the first iteration of this, that was focused in on heart failure and myocardial infarction, but we're going to be talking about the Focus MI program focused, no pun intended, only on myocardial infarction. So we have done our best to develop a compendium of best practices that rely upon delivering the very best care that you can in that care transition, moving from the acute care hospital setting to the outpatient setting. Reflected on this next screenshot here, you can see that our goal is to really make the transition as seamless as possible, not only for the patient, but the care team that's managing them. And we can all imagine, I see at my own institution, opportunities for improvement in that care transition process, largely because as a delivery system, as a hospital, our hospitals have been typically very siloed, separate from the ambulatory setting, and it obviously invites the potential of the ball being dropped, not purposely, but accidentally, in the care as people move from the inpatient to the outpatient setting. And unfortunately, it's our patients who suffer as a result of that. And this is all with a principal goal of driving down readmission rates for myocardial infarction for your respective institution. So this next slide begins to call out what we have put together as part of the Patient Navigator Program Focus MI Quality Improvement Initiative. We are really launching two programs in one. It is a national program. Many of you on the phone may be the first time you're hearing about this, and our chance is to share information about that national program. But there is also a smaller cohort group that are all focused on this quality improvement campaign driven by reducing readmission rates for those hospitalized with a myocardial infarction. The national campaign or national program involves broad implementation of a lot of the learnings garnered by the original Patient Navigator program, but applying them uniquely to a myocardial infarction patient population. The cohort campaign is a subset of the larger Patient Navigator Program Focus MI initiative and is focused on developing new strategies that support a 90-day readmission reduction overall for this group. And I'm going to pause for one moment and say many of us have been very much laser focused on reducing 30-day readmission, in part because CMS has made it a priority. A lot of the penalties have been focused around the 30-day time horizon. As some of you may know, CMS recently launched a voluntary program called the BPCI Advanced program, of which myocardial infarction is one of the disease states around this, but it's looking at bundling of services, both from a quality and cost standpoint, around a 90-day episode of care. And so going forward thinking, the American College of Cardiology was very much dedicated towards not only reducing 30-day readmission rates, but also supporting hospitals and health systems with strategies to reduce that 90-day risk of readmission overall. So when we talk about the cohort program, this is a group that has already been identified and chosen. And these represent 15 sites or hospitals across the United States, of which they participated in the original Patient Navigator program. That was requirement number one. They completed a recruitment survey, and then they met pre-identified selection criteria that included their own self-identified interest. Our goal was to roll this out, this cohort 15-site program within a program that promoted a variation in geographic location. We know that the challenges that may occur in the southeastern United States may be different from the west, and may be different from the northeast, and we wanted to be able to understand and tackle the different challenges with a goal of having a very geographic representation. In many cases, the individuals or sites had a role in connection to ACC member leadership, and we're dedicated and fixed around how best to drive quality improvement, not only for their own hospital, but for the larger U.S. population as well. And a very key important feature of this was that they had to have infrastructure to support the Navigator program, and this was a requirement that came about through the original Patient Navigator program as well. So this is a map, and it's a little bit of a busy map, but I'll take you through it here. The yellow stars, which are smaller, reflect the original 35 hospitals that participated in the Patient Navigator program, the original instance, we sometimes refer to as 1.0, and then the red sites represent, or the red stars represent, that subset of the 15 hospitals selected from the original 35 that represent that cohort group that's part of the Patient Navigator Focus MI program. If you are calling in as one of those sites, then you should already know that, or it's been shared with by others at your institution. If you're calling and this is the first experience you've had with the Patient Navigator program Focus MI, our interest is in kindling participation in the larger national program overall. So let's get into the details here. For both the national program and the cohort MI 15 sites, we are tracking a lot of quality metrics overall. And for participation in either the national or the cohort MI groups, you need to be an Action Registry participant, participating in an NCDR Action Registry dedicated for years around collecting data related to MI care, and then from that delivering best practices to drive closure of gaps related to quality improvement in the MI area. So several of the metrics that are tracked by the Action Registry are things that we will be looking at as part of the Patient Navigator Program Focus MI initiative, both for national and cohort sites. These include the STEMI Performance Composite, the non-STEMI Performance Composite, an assessment of defect-free care, the use of aldosterone blocking agents for those with post-myocardial infarction left ventricular systolic dysfunction, a look at bleeding rates, mortality rates that are actually risk adjusted as part of the Action Registry, and then in-hospital referral to phase 2 of cardiac rehabilitation overall. And for those of you that are registry site managers or involved in your Action Registry site right now, then in that situation, you should be familiar with a lot of these metrics overall and very familiar with the metrics that are tracked as part of the Action Registry. However, the interesting part about the Patient Navigator program is shown in this next slide that's here. That's a look at the national and cohort MI metrics related to care transition. And these are things that are not tracked as a matter of routine in the Action Registry, and so these may be new to you. But we know from a lot of accrued data and information in the literature that understanding rates of readmission, measures of patient satisfaction, how you even identify AMI patients. It's really hard to close gaps in care related to an AMI patient if you don't even know who that AMI patient is real time. What is that risk of that patient's, what is that patient's risk for readmission? And then the importance of medication reconciliation. So as participants in the national group for the Patient Navigator Program Focus MI, in addition to tracking Action Registry metrics that are already submitted, and no additional work is required because those are already collected by your site, we are asking both groups to look at other care transition metrics listed on the left-hand side here and others listed on the right here. How effectively was a discharge summary communicated to the recipient who's going to receive the baton and care for that patient post-discharge? Are there patient education and self-care plans around the best practices and medication use that have been distributed to the patient and shared with them? Has information been provided related to community resources to be a resource to patients to drive down the risk of readmission? And so these represent a subset of the other additional metrics, these sort of areas in which we are asking national and cohort sites to track data that would then be uploaded and submitted to the American College of Cardiology through the National Cardiovascular Data Registry NCDR portal that's connected with the Action Registry for those that participate in this program. So getting started, this may be top of mind for a lot of you. How do we go about doing that? In the case of getting started, it's really important that all of you on the call, and probably taking this back to other key leaders at your institution, that you review the program requirements. And it's beyond the scope of being able to go through every requirement on the call today, but we're going to tell you where to go to look to get all that information. Once you've reviewed the program requirements and you green light it, you give a thumbs up and you say, I'm ready to join in, we'll need you to opt in to participate in the Patient Navigator Focus MI program. You will be required to log in using your NCDR username and a password to be able to opt into the program overall. Ultimately, and I think this cannot be overstated enough, and it's often glossed over for a lot of different institutions, my own particularly in the past, is it's really, really important to develop a multidisciplinary Navigator Focus MI team with a group of champions. And let me be clear, this is not by any stretch all-inclusive of all individuals who are involved in MI care. But I would dare say it's really hard to move mountains in terms of closing gaps in care related to myocardial infarction unless you have buy-in and engagement and dedication by a service line administrator, by a key physician lead, or an individual who assumes responsibility for overseeing the program's implementation and the quality improvement closure of gaps that occur as a result. And then equally as important is a nurse champion playing that role as well. And while this doesn't take into consideration cardiac rehabilitation staff, pharmacists, care managers, nurse educators, ambulatory care providers, ambulatory nurses, and I'm leaving a ton of individuals out, it's really important to have this triad of a service line administrator, a physician, and a nurse champion to drive this improvement overall. Finally, you'll need to submit your hospital's data, both in terms of baseline data collection period, as well as subsequent quarters in terms of reported data going forward overall. So I just want to point out for you, if you're unfamiliar with this website, you should be able to find the American College of Cardiology Quality Improvement for Institutions site that is pretty easy to get to. For those of you that have been an NCDR Action Registry site, this is probably very familiar to you, but if you haven't seen it before, it offers a wealth of information above and beyond what I'm going to share with you right this moment. Listed on the right underneath probably the fourth tab in white list clinical toolkits. There are also communication kits. There are a number of other resources that are very helpful. But under campaigns, what's listed as a second tab, the fourth one down says Patient Navigator Program Focus MI, and this does provide one way to be able to get in and opt in for participation in the program. And once you click on that Patient Navigator Program Focus MI, you will then see information, and this is covering up a little bit of the text that's there, but in the second paragraph listed in blue is a link to take you to the opportunity to opt into the program. As you can see here, there is the opt-in. It does involve a directive to the registry site managers that to opt into the program, you do need to acknowledge understanding of the program requirements by clicking the box below and submitting. You can see a little box here, and then obviously the submission button. This next one is just a blow-up showing a similar verbiage, but come about through a different way. So for those of you on the phone that are registry site managers, you're probably used to this type of a screen. This is the NCDR Action Registry portal that allows you, once you've logged in, to be able to access lots of different information. But as you can see here on the left side under administration, there is a Patient Navigator Focus MI section, and it does allow you to be able to opt in to participate in the program this way as well. The same attestation is listed here. Clicking the box, hitting submission. We've just provided you essentially two different ways in which you can actually see the information overall. Once you have opted into the program, it is important to know that the registry site manager will need to assign essentially roles and responsibilities of certain individuals that can have privileges that may include viewing functionality but no uploading of data. It may involve uploading of data but no viewing of data, etc. And as you can see here, this is a just blow up of the privileges that can be granted by the registry site manager to different personnel that work within your facility overall. As you can see here, part of the privileging that needs to be given is the ability to A, have access to the survey collection tool. This is how you actually upload your information, and a separate checkbox for participation in the Patient Navigator dashboard, which allows you to view the tool, view the data subsequent to its submission overall. And I would say in many cases it may be one and the same individual that has access or privileges to both functionalities, but there may be circumstances at your respective institution where you want certain personnel to have access to certain things and not others overall. If we go to this next slide, what it highlights is under the Patient Navigator program, under the dashboard, there is a survey collection tool. And ultimately, by opting in and participating in the Patient Navigator program Focus MI national group, this is true for the cohort group as well, but for those of you exploring the national program, this is how you would actually submit and upload your data. And as you can see here, there's some verbiage about the excitement of launching the program, and some information about the ability to not only submit your data, but access national benchmark data and understand where your facility sits, not only with regard to traditional action registry metrics, things like the STEMI, non-STEMI composite, defect-free care, but look at transition care metrics that you will be collecting and submitting and uploading that will be benchmarked against colleagues, other facilities across the country, that will allow you to understand where there may be opportunities for improvement as it relates to care transition metrics. I will call out also the first bullet point listed here that notes that the date of entry for baseline data is looking at data from the fourth quarter of 2016 through the third quarter of 2017. So let me restate that. By participation in the program, we are asking all facilities to upload data understanding their performance for these transition care metrics between the period of quarter 4 of 2016 through third quarter of 2017. And let me be clear, it may be that some of these interventions that are best practices around transition care may not have been employed or done by your respective facility during this time horizon, and that's okay. Our hope would be to be able to move the needle over time by sharing performance from your facility benchmarked over time as well. Ultimately, this is a tool that you may be familiar with, but it ultimately allows you to be able to create new surveys, essentially uploading of data this way that will allow you to submit your data on a quarterly basis. You can see that this section is broken down into new surveys, if you will, the future surveys that exist. There are pending surveys that may have been started but not completed, and then there is a section for completed surveys. So this allows or affords you the ability to figure out what have I already done and uploaded. I've crossed that T, I've dotted that I, and I'm done with it. What are those surveys that I am due to complete but it's in progress, have not yet completed, and then what sort of the future state surveys overall. Listed on this next slide is information about the ideas of questions that we will be tracking overall. And for those of you that are registry site managers, particularly for the Action Registry, this is probably stuff that you are familiar with overall. And it's getting maybe a little bit out of turn, but what we will be looking at is, A, the data that you submit through the normal submission process for the Action Registry that's collected as part of the Action Registry today will not be expected to be re-entered. But as you can imagine, as part of the survey submission process, those transition care metrics that we're asking you to track and report on that are not captured as part of the Action Registry participation historically will be things that you will need to manually enter data into to upload into the system. And as you can see here, when you enter one of the surveys for a given quarter, there's a survey list that lists in for the first thing listed, instructions. As you can see there, as you've completed specific components, a little green check mark appears that will give you a high-level 30,000-foot view to get the perspective on what needs to be done or what has been done already. As you can see here, the second metric or the second item listed on the left side is MI 30-day outcome metrics. And as you can see here, it asks 3 questions. Questions 1-1, 1-2, 1-3. This is data collected, and it tells you where the data source is, in this case, the CMS Hospital Compare website. And it asks the question, what is your hospital's annual CMS 30-day risk standardized readmission rate for AMI patients? Please enter that percentage that's listed there, and it allows you then to upload that data as you go along. On the left side, these metrics have been chunked based upon outcomes, patient satisfaction metrics, process metrics, either those that are collected as part of the Action Registry or those that are self-reported from the individual facility. This is an important reiteration of what I've stated a few times previously, but when you can see there the 4th item down on the left side listed as Process Metrics Action Registry, that relates to those metrics that are tracked as part of Action Registry historical participation and data submission. These are those same metrics that we called out earlier. You will not, and I want to underscore the word not, be expected to resubmit or reduplicate your efforts in terms of uploading data that you've already uploaded as part of your hypothetically first quarter of 2018 data submission as part of Action Registry participation. So this just reflects that it's a placeholder for that data to be also looked at down the road, and it's a subset of all of the metrics that are tracked as part of Action Registry participation. Again, one more time, you will not be expected to resubmit that data. It will populate into this area from the normal process in which you submit or upload data as part of Action Registry participation. I'm going to pivot and change directions just for a moment and highlight the fact that what I mentioned earlier on is if you go to the 4th tab under the Quality Improvement for Institutions or QII website, one of the first things you'll see there that's encircled in this case in red are the QI or Quality Improvement Toolkits. And it's an unbelievable resource, but there are a number of very helpful quality improvement resources that are available to you today, and we would encourage active pulling up of this information as participation in the Patient Navigator program, whether in the national or the cohort groups, because these are a compendium of best practices that will help you address issues going forward. A little bit deeper dive, if you go under the QI toolkits, there's an introduction to the PDSA model for rapid cycle quality improvement, and maybe this is all too familiar with many of you and your individuals at your respective institution, but if it's not, it serves as a helpful resource overall to drive best practices. Obviously, on the QII website, one of the questions is, what are all of the program metrics? And to make sure that I have a firm understanding of what we're getting ourselves into, we're all very excited for enthusiasm by all of you to get participating in the program. But we want you to be, and we want to be very transparent, what are the program metrics that it consists of? And so this is encircling, as you can see here, what those program metrics are. And allow you to feel comfortable that when you opt in, you've reviewed all of those metrics overall. This next slide talks about getting started and sort of just a checklist of things that one should be thinking about what it means to get involved in a quality improvement initiative, whether done on a local level or on a national level overall. And I think one of the most important resources listed on here is organizing a quality improvement team. Now, it may sound strange to actually put pen to paper or type into a box who these individuals are, but I really do want to call out the importance of selecting administrative, physician, and nursing leaders who will form the triumvirate, the triad, to help oversee this program. It very well and probably should include a facilitator or a program manager to be able to facilitate this work being done. Now, these may be one and the same individuals. And then finally forming that project team. And that project team, as many of us know, there are many more people that sit on your team that drive quality improvement overall, particularly around myocardial infarction care, and I'll go one step further, particularly around the period or around the area when you move from the hospital to the ambulatory setting overall. Listed down here is the fact that there are assessments that are done. So we're asking sites to do an online self-assessment. This is not a test for testing's sake, but this really allows you to understand, do I know our current state performance for our institution, for our hospital? If I don't, then this is an opportunity to learn about data that is being tracked at least by CMS overall. The second thing that this does is it invites a rigor that of saying, I don't know if we're tracking it, but I believe we are. Where are you able to get that data from? So it's a very helpful thing to start thinking about where are those data sources at my respective institution. And I dare say an initial challenge, but easily overcome by sites, is to figure out who at my institution is tracking this performance. And it may well be, and in most circumstances it is, that somebody has their finger on the pulse of this metric, but it may in some cases be different individuals for different metrics overall, depending upon the respective size of your institution. Finally here is we do want to underscore the fact that you're not doing this alone. And the challenge with this is it's very easy to feel like one is alone when embarking on an initiative like this, in part because it seems in some cases challenging to address different metrics, perhaps all at once. And so we have tried to create a community, both through webinars such as this, and admittedly this webinar is to give you information and background about how to participate in the program, but subsequent webinars will be focusing on specific challenges and how sites have overcome those challenges. And we also have created a listserv that became very popular in the Patient Navigator 1.0 program, where sites would say, listen, we're airing our dirty laundry. This is a safe community. We really feel comfortable with all of you, but how in the heck are you doing effective implementation in community resources out there? How have you actually showed this with patients? How have you showed this with nurses in the hospital? How have you showed this with nurses in the clinic? We're having a challenge with MedRec. Who's using pharmacists? Who's using pharmacy techs to do that? How are you engaging your physicians around that work overall? Where do I find what our CMS performance is with regard to unadjusted 30-day readmission rate for myocardial infarction? Where do I go to? So those are the types of questions that can be pushed out. And then as a community, since you're a part of it as well, but all of you who may opt in, you have the chance to reply back and say, this is where our site gets it, this is the person you may want to reach out to, etc. Really trying to create that safe environment of a community feel where you really feel like you can reach out to someone who's not at your own institution and ask and get questions responded to in a timely fashion. And I'll be honest, the one thing that we can't guard against is, in many cases, you may get 5, 6, 8 responses where people are saying, this is where I get it. Everybody will be copied on that, but it really creates a cohesive community feel, even though you may be interacting with a site that's 2,000 miles away. So this next slide highlights the fact that we're not asking you to go into territory unarmed. And this is sort of our black book of a compendium of best practices. But the reality is for every metric that we have identified, we have similarly tried to provide a resource for you to figure out, how do I solve this problem? So in the case of 30-day unadjusted readmission, we provide readmission templates, readmission interview tools that may be used to allow people to query why a patient got readmitted, and then be able to figure out, aha, there's a theme here about why patients are being readmitted. How do we close that gap overall? When it comes to medication reconciliation documentation, number 9, it's listed about 2/3 of the way down, we have some information about how to engage pharmacy services in MedRec or counseling related to this overall. In some cases, about a discharge summary, item number 12 being available, there is a discharge checklist for AMI and for heart failure that we have on there, but another resource to help drive best practices and closing of gaps overall. So it gives you an idea, and this is by no means a complete list, of what are those best practices. I don't have to reinvent the wheel. I don't have to go searching. We want to serve it up to you on a silver platter so you can say, I want to know where all of these other sites have gone through, what they've utilized up front. Let me learn from others who have gone through the process overall. So this is a really important moment to pause here and just say it's really hard to close gaps unless you know where those gaps exist. So this is calling out in this slide the importance of identifying areas for improvement, and I'm not going to get up too much on my soapbox, but I'm just going to say every one of us on the call, myself included in my institution, have opportunities for improvement. Nobody is hitting on all cylinders in every one of these metrics. And it's certainly true that we found in the Patient Navigator program, we may have sites that are doing phenomenal in referring people to phase 2 of cardiac rehabilitation, but their use of aldosterone inhibitors for post-MI LV systolic dysfunction is at the 10th percentile in the United States. Or I have a really high rate of readmission, but I'm doing med reconciliation and providing discharge summaries really well. And so this is really a calling out to say we all have areas for opportunity, and if we can learn from each other about how gaps were closed from the others, whether through a listserv, through webinar, through offline conversations, all the better overall. But it's really hard to do that unless you know the areas for improvement. And this comes back to that survey instrument that we talked about earlier, where we would allow you to do a survey, a sensing of where those gaps may exist. So it really is encouraging you to drill down on each measure, prioritize your areas for improvement. How does this impact patients overall? Obviously, this starts once you've identified that triad of a administrative, nursing, and physician leader to really then define your goals. And this SMART acronym, I think, is really helpful for me. It's been helpful for a lot of sites. But in defining those goals, you want to be very specific. You want them to be able to be measurable to know that whether you've moved the needle. You need to have goals that are attainable. So it's unrealistic to say we're at 20% of patients being referred to phase 2 of cardiac rehab, but by 2 quarters into this, we're going to be at 100%. And those are lofty goals, but they need to be attainable. They need to be relevant goals. So obviously, you could have the greatest goal in the world, but if it's irrelevant, it really doesn't help. And they need to be time-based goals and setting attention to saying, over this time horizon, we need to achieve this. Now, you may falter, you may fall short, you may exceed those goals, but then it allows you each quarter to reevaluate where things stand and how do we parse out more effort into one area versus another based upon that overall. And again, putting pen to paper or typing out, this allows you using the SMART goal worksheet to identify what's your intent, to be specific, to have a measurable goal, how much, how often, how many. Is it attainable and achievable? Is it relevant? Is it time-based? So this gives you, again, another instrument to help assist with this overall. In terms of all of this, it really then, and I would say that the people, the 35 sites that participated in Patient Navigator 1.0 will say that the discipline invited by this process, participating in a national quality improvement initiative, invited really some detective work of understanding what's going on currently. What is our current process overall? Who are the stakeholders? And then what is the process that we ultimately need to get to? And I dare say, as is true with implementing an electronic medical record, rolling out a quality improvement initiative, it's sort of like lifting up the rock and seeing all the creepy crawlies that come out, because you realize, guess what, we have 6 different ways that people are going about this. And it's not to say that one way is always the right way. There may be a method to having more than one way, but where there isn't a method to having more than one way, how do you harmonize a common process and about implementation of best practices in a consistent way so all stakeholders are on the same page? So this is, how are even patients identified? What standardized order sets or protocols are in place? What systems are in place to catch oversights so gaps don't exist overall? And I think those are the kinds of questions that we want to ask, and we'll put the discipline behind each of you asking overall. To that point, we will help support you in developing and implementing your plan for improvement. So when you've selected a goal, it might be, and this is one that is perhaps relevant or not relevant to this group per se, but we want to increase the rates of an ACE or an ARB and evidence-based beta blockers in those people eligible for an ICD with, hypothetically in this case, post-MI LV systolic dysfunction. And then it'll allow you, by tracking into action, what is our baseline state, our performance? What's the 90th percentile look like? What is the source that we go to? And I would say that this is not the best example because it comes from the ICD registry as opposed to the action registry, but the concept is the same. And then you would state a goal. Our goal is to move from 78.8%. We know we're not going to be realistic in getting to 100%, but we want to get to 95%. And the time frame is 1 year. And then it invites you, step 2, what are the barriers related to this overall? And then how are we going to measure that going forward overall? So it gives you a perspective and a process to select goals, understand where you exist, understand the barriers and the processes to overcome it, and then how am I going to measure success going forward overall. So in this situation of the example that we just gave of a goal of increasing the rate of ACE-ARBs and evidence-based beta blockers for that patient population, the critical steps obviously are required are abstracting and looking at the data produced as a part of, in our case, it's going to be the action registry metric in particular. How do you bring that up at process improvement or quality improvement meetings? It often comes up to say, I have no idea the data definition related to this. Hopefully there are people on the phone who I can't see who are nodding their heads. And then it requires abstractors or other site managers to provide clarification of the data definition for that metric, etc. And I think this really is an iterative process. This doesn't happen overnight. I can tell you, in my own experience, it doesn't happen by like a light switch, flipping the switch, and all of a sudden there's an aha moment, and every provider just does exactly what they're supposed to do. It's an iterative process which requires ongoing provider education, understanding the definition of the metric, what the metric is measuring, how we're performing, and then where do we benchmark, and then what are the solutions for closing gaps in care overall. I think calling this out is identifying potential hurdles or barriers to success, and then who are all the stakeholders that we need to talk to. And I think that's really important to call out because frequently we think of only one stakeholder and don't move the needle as far as we could because we didn't do as good of a job in terms of identifying the full aggregate of stakeholders overall. Going to this next slide, it's important to call out that we have a number of webinars already planned. We can make this information available to you, but I believe an email has already been sent out with dates so you have them in hand. But the next webinar is planned for April 11th from 12 to 1 Eastern Standard Time. I'm on the West Coast, so I'm sympathetic to those of you who don't necessarily have a day that's blocked out just between noon and 1, and we very much appreciate those of you that have gotten on where it's not during your lunch hour. Webinar 3 is on June 20th, and Webinar 4 is planned for November 29th, and the themes for those have not yet been identified, but we're enthusiastic and hope that we have active engagement and participation by all of you, and warmly welcome for you to bring any and all personnel, not just the service line administrators, not just the physicians and nurse champions for that program, but share the link and webinar information with your cardiac rehabilitation staff, with your care managers, with your in-hospital nursing staff, your out-of-hospital nursing staff in the clinics, etc. So it's an exciting time for us, and these are amongst the most fun things that we do in terms of sharing best practices and having people have that aha moment. And it might be that you say, this speaker, it didn't really resonate for me and we couldn't replicate what they've done. But speaker 2 and 3, that I can really get behind. And we don't believe that there's a one-size-fits-all solution, but we're trying to, as our best as possible, deliver a range of best practices that exist. In terms of contact information, you can obviously go to acc.org. There is a call center. There is also an email. Obviously relates back to the action registry with the NCDR at acc.org as well. And, I'll call out, this is an open-ended question, but are you ready? We're really excited about this initiative. We know that there is a bullseye on MI 30-day readmission historically going back several years. If the BPCI Advanced Voluntary Initiative is any indication of where things are going, we're now looking at a 90-day time horizon. And so thus the reason in particular for the cohort group that we're focused in on that group as well, that timeline as well. And I dare say that going forward, you will find that the time horizons that CMS is looking for is not just about how do we keep people out of the hospital healthy and avoiding accessing medical care where they don't need to. I want to be clear. They need to access it any time they need to, but where it's preventable, unnecessary, they want to extend it out further and further. And this will be a little bit emotionally charged and worrying maybe some of you, but CMS is even for some other disease states unrelated to AMI looking at even one-year time horizons. So I think what they're getting at is we need to function more as a coordinated, cohesive delivery system, and I recognize there's a lot under the hood there when we say coordinated because it's, well, how am I responsible for something that happens 27 days or 87 days or 600 days after they get out of the hospital? CMS and the government is at least expecting us to think more and focus more that way going forward. And so with that, I just want to reinforce the fact that those of you who have not done so already or maybe jumped on a little bit late, you can type in questions in the chat box on what I'm envisioning to be your left lower corner of your screen, and I'll do my best to answer questions as they come up. The next webinar, again, is April 11th of 2018. So I'm going to take a couple of questions that have been typed in thus far, and I'll address as many as they can. If we end up having no further questions, we'll certainly cut the webinar short, but I want to make sure I entertain any and all questions as they come in. So an individual has asked, is this program free? So yes, opting in to participate in the Patient Navigator program for the Focus MI National Group is free to participate. I want to qualify that by the fact that you have to be an action registry site. This is not involving of the waiving of the registry participation fees associated with that. And obviously we all know, and I know very well, there are costs to resourcing the data abstraction and the submission of that data. Those costs are not covered by the program. But the ability to be able to opt into the program to upload and submit your data, not just the traditional action metrics, but those care transition measures that allow you to be benchmarked against individuals across the country, there's no additional charge for participation in that. Another individual asked the question about was the baseline data 2016 Q1 through Q4? No, we had set things up from the get-go, and it'll probably take a while to scroll back to this, that always it was the baseline time interval that we had defined previously that was from fourth quarter 2016 through third quarter of 2017 as the baseline time period, and that was to get us as close to in time the duration or the period that would be reflective of the launch of the program with delivery of interventions that would move the needle. And so that was the time period that we chose. We're still adhering to that time period as the baseline period. And the ask and expectation would be to opt into the program in addition to agreeing to participate, but part of that agreement involves submitting not only your baseline data, but your quarterly data going forward there afterwards. I see here that somebody has said that they tried to join the listserv and got a delivery error. Can you verify the email to join? I am scrolling back right now because off the top of my head I can't tell you the listserv. There it is. If there are any errors, we will on our technical end confirm that this is working right this moment. And if it's not, we'll be sure to communicate out a solution for you as it relates to this listserv. Another question that came up is we've only started doing non-STEMIs in addition to what I'm envisioning being historical STEMIs. Would we qualify for participation? So the Action Registry has always asked people to submit all myocardial infarctions. Obviously, at this point is if historical data for you is reflective of only STEMI performance, but going forward, you would have the ability to submit data for non-STEMI and STEMI. We would warmly welcome your participation. I recognize that the STEMI and non-STEMI populations are different populations overall, and so there may be a little confounding by the fact that we're looking at an apples to oranges comparison, but we would actively encourage you to upload your data for all of your MI patients, and excited by the fact that as of January 1 of 2018, you're now doing it not only for STEMIs, but non-STEMIs as well. I'm going to pause for a moment because I think we have addressed all of the questions that I can find thus far in the chat box. I'll also make sure that I open this up to Julie, Susan, and Valerie, who are part of our core team for the Patient Navigator Program Focus MI Quality Initiative. Certainly willing to have them participate or pipe in if there's any things that I've missed. But we're really excited about this initiative. We're excited to be able to move the needle for many of you. We know that you will have to ultimately focus on key goals, and you can't, it is literally boiling the ocean if you try and address every single thing, but we believe that we've put together a program with aligned resources that will be to the betterment of your respective facilities, whether you're in California, Florida, or Maine, and everywhere in between. Looks like there is an incorrect listserv address in the actual webinar that we have here. I will read it off to you, but we'll be sure to circulate this to you as well. It is missing the OCUS in this. It should read P as in Paul, N as in Nancy, P as in Paul, FOCUS, or focus, MI, all one word, at lists, lists.acc.org. So again, we're missing the OCUS in what's on the screen for you right now. Again, PNP, focus MI, at lists.acc.org. Thank you, Valerie. I'm going to pause for one more moment and see if there are any last questions that people have. It's been a sincere pleasure to have the opportunity to be able to share all of this information. We're really excited about this, and we warmly welcome questions that you may have, but obviously engagement and participation in the program, as we believe that this is something unique that we've launched uniquely even above and beyond the Navigator 1.0 program, insofar as making this available to a lot of other sites that were not a part of the original cohorts or a part of the 15-person cohort overall. With that, I will just leave the reminder that the April 11th of 2018 is the next webinar. It's been a real pleasure talking with all of you today. We will archive this on the website so you can share this audio and sharing of slide recording with your colleagues at your respective institution. And we wish you all a wonderful day as well. I will say that we are going to be doing a similar live discussion at the NCDR conference annual meeting forthcoming. So for those of you that were on today that have questions and you want to bring them to the upcoming meeting in early to mid-March at the NCDR annual conference, or you want to just come for a part 2 of the same thing you just heard, or you want to encourage colleagues that couldn't be on today, we warmly welcome the opportunity to share a lot of this with those of you that are attending that as well. Come engage for the NCDR annual meeting. It's been a real pleasure, and I hope you guys have a great remainder to your day. Eric, I think that concludes